My name is Yahya Thawi. I'm a consultant neonatologist and a pediatrician. And today we're going to talk about interpretation of blood gas. And it is an episode of a series of talk about ventilation. And there will be 2 more talks about this topic. The next one will be about setting, maintaining, and weaning from ventilation in addition to patient ventilator asynchrony and of blood gas. Now, the objectives of this talk is to tell you some definitions, and then we'll talk about some general tips, and we'll talk about pH and buffers. We'll talk about how to sample and what is normal gas. We'll talk about a little bit of acid-base status, and then reading blood gas slip and how to process. And we'll talk about a little bit about chronic versus acute changes. And also we'll talk about compensated versus non-compensated. And we might have a chance to do some differential diagnosis, although I won't go in detail of that. You guys can read it. So pH is, what is pH? It is a free hydrogen ion concentration. And the number of the pH is inversely related to hydrogen ion concentration. What is acid is a substance that can donate hydrogen. And when you donate hydrogen to the body, you drop
Hello, sir. Can't hear you.
while alkalemia, when the number of pH number is more than this number, it's more than 7.35. However, acidosis is different from acidemia. Acidosis is the process or the disease or the problem that lead to acidemia. And this process is either increasing acid, and we said acid is the substance that donate hydrogen, or decrease alkali and decrease in base, and the base is the substance that can accept hydrogen. Alkalosis is the other way around. It's an abnormal process or a disease or a problem that raises pH. And I'm going to ask you again to mute your mic, please. So alkalosis is raising pH due to decrease in acid or increase in alkali. And my apology for pausing, because I receive text and I receive people coming in again and again and unmuting their mic. So please mute your mic. Please mute your mic. Thank you. Please mute your mic. If you don't know how to mute your mic, you should be joined earlier, so you know that the technical difficulties. My goodness. So, as we said, my goodness, this is not going. I'm gonna lock the room so nobody will go. Will enter again. iPhone Hussam, please mute your mic. I muted your mic maybe 6 times now. I'm gonna, if that happens again, I'm gonna remove you from the meeting. So again, alkalosis is the process, and what we need to know also the what we call it actual bicarb, because gas sometimes reported the bicarb is in a different way. It's a measured bicarb, but also can give you what we call it calculated or C bicarb. So you need to know when you look at the clips what you are reading. And the calculation of the bicarb is different for various machines, but basically it's derived from the pH and CO2 using Henderson-Hasselbalch equation. We will talk about this. However, the biochemistry will measure the bicarb by enzymatic assay. So it's measured, or M at CO3, not calculated at CO3. The other things is you need to know is what's the indigenous source of acid. There is daily production of acid about 1 milliequivalent for each kg in the body. And they derive from different substances. I don't want to list them all, but there are many substances that can provide you with the list of pH, of acid, sorry. Now the pH, normal pH regulated by between 7.35 to 7.45. And there are 3 players controlling the pH. There is the respiratory response, and there is the renal response, and there is also what we call it chemical buffers. Now the chemical buffers is the very quick response, so which either release or accept hydrogen ion to minimize the changes in the pH. And who gives the hydrogen ion is the acid, which provide or donate hydrogen, or alkali, which can accept the hydrogen. And the chemical buffer is the first line defender of the switch or change in the pH. So as we said, acid will donate hydrogen ion, while base will accept the hydrogen ion, sorry. The other buffers, the buffers or the chemical buffers are of 2 types, either intracellular or extracellular. The intracellular buffers can be hemoglobin, can be intracellular protein, can be phosphate. because the hemoglobin inside the RBC. And there is also extra cellular buffers like carbonic acid or protein or ammonia, and the control of the pH using Hasselbalch equation. And in this equation, you will see that the water combined with CO2, and it's a weak combination that can give you bicarb and HCO3. I mean, HCO3 and hydrochloric acid. Sorry for the interruption, always interrupted, and I lose my concentration. The respiratory buffers on the other side is the second line defense. It can generate every day, the body can remove or generate about 10 to 20 mole of CO2, and this CO2 should be removed. And then from the production of the CO2 in the body, in the cell, to reach to the body, it's being carried by the hemoglobin. And the hemoglobin that carries CO2, we call it carboxyhemoglobin. And when it reaches to the lung, it's as a gas, it will be exhaled and removed. But also, it can combine with water and generate CO2. So therefore, the pH with the respiratory status can change within minutes. When there is acidosis or a process that can cause acidemia, okay, I have a question. The questions will be at the end. So if you have a question, will be at the end. Samiha, please mute your mic. So when there is acidosis or a process that causes acidemia, the chemoreceptors at the carotid area, and there are various places, feel that change in pH. And that will stimulate ventilation. And therefore, when you go, for example, up above the sea level, you get hyperventilation. And when you go in a place when you got hypoventilation, and when you are premature and you don't have these sense, you get periodicity because of that. So acidosis is a very important stimulation for ventilation, and then ventilation will wash CO2. On the other side, alkalosis has two phases. The first phases will cause hyperventilation, and that will cause hypoventilation. Sorry, that here is wrong. Alkalosis will cause hypoventilation and will increase CO2. And the second phase will cause hyperventilation and normalize CO2. Sorry for this mistake. This is hypoventilation. The renal buffer, on the other hand, regulate any non-volatile acid and alkali, which is non-CO2, non-bicarb. And it does that by adding acids or losing bicarb. For example, in premature babies, you have immature kidney and they start to lose their bicarb and they can get acidosis. And that's the only indication in prematurity to give sodium bicarb. So part of this renal buffer system is not mature in newborn babies. So the kidney add acid like citrate or remove bicarb to control the pH. And acidosis, either filtering the bicarb and conserving it. So when the kidney lose the bicarb, it's get reabsorbed, or it regenerate and form a new bicarb. That's the only way the kidney deal with the acidosis. Now, what is the actual bicarb level? The actual bicarb level comes from an equation of multiplying 0.03 times the CO2 and times 10 to power of pH minus 6.1. It's a difficult equation. You don't need to memorize it, but this is the actual bicarb. This is the number that you will see in the blood gas. However, if you measure the serum, and when you do a electrolyte, you will see that actual measurement, which is done by enzymatic assay. Now, how we sample blood gas? We have three routes to sample blood gas. The first one is by arterial blood gas, or the ABG, but also we have venous blood gas and we have a capillary blood gas. The reference value for blood gas, the normal blood gas, and the reference is ABG, or arterial. And the arterial can be taken from radial lines, umbilical lines, from dorsalis speeds, from posterior tibial, and from femoral. Now, the capillary blood gas can mimic the arterial blood gas. However, you have to do something called arterialization, which is basically warming the foot before you do heel break to get the blood gas, or you do it from the thumb or from whatever from ear lobe, from wherever. You have to warm it, and when you warm it, the CBG, or the capillary blood gas, become close to the arterial blood gas. However, even with that, when you do a CBG, the pH of the CBG is slightly lower than the pH of the arterial blood gas, and the PCO2 is slightly higher. And you'll never comment on O2 in a CBG. So do not, although the machine will give you that number, but you should not use it. Now, I didn't close the talk because I received a message from somebody that the electricity might get off and on, so I kept the room open for people to join. So again, you do not comment or use the PO2 in CBG. The venous blood gas should not be used. The only indication for venous blood gas is for oxygen consumption rate. So you have an arterial blood gas and you have a venous blood gas, and then you can see how much you are using or from oxygen. And the pH is of the venous blood gas, because it's after the metabolism, it will be slightly higher on alkalotic side, and also the PCO2 is slightly higher, and the PO2, of course, of no value. When we say normal blood gas, we're talking about a room temperature. So if you have non-room temperature gas, like if you are cooling a patient, or your patient is hypothermic, or your patient is febrile, this is not considered a normal gas. You have to titrate that. Either change the temperature of the gas machine to match the temperature of the patient, or adding or subtracting from the reading to be comparable. So when we say normal blood gas, we're talking about 37 degrees Celsius. And usually it's between 7.35 and 7.45. However, when we say this number, it really varies. Or what we call it, instead of calling it a normal pH, I would say it an acceptable pH. And the acceptable pH varies with the gestation, with the age, with the weight, with the gender. So I usually do not like to give a number. The normal PCO2, and again, I don't like the number normal. I would like to change this number according to the scenario, but the normal would say 35 to 45. A normal PO2 is about 50 to 95 millimeter mercury. Now, this is a list of normal gas, and you can see the difference between premature babies at a different gestation term and pediatric. And you can see the higher age you go, the range become wider. The range become wider from less very narrow window to a very wide window. And these number are a copy. You don't need to memorize them all, but you need to at least have an idea about pH. And then when we present cases like of premature, you will know what is normal. So for example, it said that the pH is here, the acceptable is in a preterm baby is 7.25 to 7.32. Actually, I accept any pH down to 7.20, if otherwise the baby is fine. So this number. I don't want you to take it like obsolete. It really varies. So it's good to have a normal number, but it's always remember that you should have something called acceptable number and then permissible number. So you need to really have a good sense of judgment when you decide about numbers. And remember these, the PaO2, the PCO2, and the pH are directly measured, while the bicarb and the base excess or base deficit, and the difference between base excess and base deficit is the number. So when we say base excess, we mean positive. When we say base deficit, you mean negative. However, if you put a sign in front of it, like negative or positive sign, it doesn't matter. If you say base excess minus, it means base deficit. Now remember that when we have a normogram, we're talking also about because remember that the PCO2 and sorry, the hemoglobin carry the PCO2, the CO2 as a carboxy hemoglobin. And when we do the normogram or normal values, we're talking about normal hemoglobin, which is 14 to 15 or 14 to 16. And for example, in a premature baby, the hemoglobin can reach up to 20. So, and that means that will have a higher carry capacity, and that will have a lower than the real CO2. So always remember to check your hemoglobin when you're commenting on your blood gas. And again, the temperature of the machine is 37, and always we are assuming saturation of more than 88. And saturation is the percentage of oxygen carried by the hemoglobin. So if you are desaturating, your CO2 will be falsely higher, because the CO2 will have a higher room to join the hemoglobin. And therefore, please remember to look at your hemoglobin when you comment on the gas, and also look at your SAT monitor. If you're desatting, then it's probably not a good idea to do a blood gas. And look at your temperature. And if the patient is a febrile or patient have low temperature. It's very important to remember these numbers when you do comment on normal blood gas. Now, the acid-base status, either you have metabolic acidosis or metabolic alkalosis. And basically, metabolic acidosis mean dropping of PCO2 and dropping pH. And metabolic alkalosis mean increasing CO2 and increasing pH. And when we have metabolic acidosis, usually the pH is inversely proportional to amount of the CO2. While respiratory acidosis, you can see that alkalosis, we're dealing with bicarb, while metabolic, we're dealing with bicarb, while respiratory, we're dealing with CO2. So respiratory acidosis is increasing CO2, and that's mean you drop your pH, while alkalosis, where you are washing the CO2, and mean that your pH will increase. Now, how you approach and how you read a blood gas. It's a very vital to look at the previous blood gas, if you have one. Like, for example, I'm giving you an example here. You have last 5 blood gas showing metabolic alkalosis, and you repeat the blood gas, and all of a sudden, you're having metabolic acidosis, and all of a sudden you have metabolic alkalosis. Then something is wrong. Sudden change means lab error. So you have to repeat. So it's very important to look at previous blood gas, and do not comment on a gas if they told you that there is a previous gas. When you check a blood gas, do not comment on one abnormal value of the blood gas. Look at all the parameters. And always look at how the sample being collected. Is it venous? Is it arterial? Is it CBG? For example, arterial is very good to look for pH, PCO2, and PO2. However, venous is not good for anything. It has much lower pH, It has way lower PO2. It has higher CO2, but it's very good, the venous, to measure the bicarb. And therefore, it's good, always good when you calculate anion gap to include bicarb in your electrolyte request to test the lights. So venous blood gas is only good for bicarb. And again, it's also good to the oxygen consumption rate, where you have arterial blood gas and venous, and you know how much your body or your tissue is consuming. Capillary, or the heel stick, or also you can use it from thumb or earlobe, is good for looking at the pH and PCO2. But the pH will be lower than the arterial. The PCO2 will be higher. And please do not comment on PO2 from the capillary. And when you do arterial blood gas, it's the best, or these ideal numbers are from indwelling catheter. If you are using intermittent stop or puncture, then you will have sudden drop of PCO2 and PO2 because of the vasospasm. So remember also these variables when you do stop or you do a puncture, one puncture, when you're commenting on ABG. Remember, when the patient become upset, you can change your CO2 or bicarb. So always consider whether your patient is sedated or not sedated, crying or not crying when you comment on your arterial gas. And when you do a CBG, also look for perfusion. If your perfusion is poor, you will get crappy CBG. But when you have arterial, even if you have poor perfusion, it's a correct sampling. Even when you have ABG, it's considered, is it like preductal or postductal in premature babies? It's not important in pediatric, infant, and adolescent, but it's very important in premature babies if you are a PDA to make sure that you are doing preductal from right hand, or you are doing postductal from UAC or from radial line or from dorsalis speeds or from posterior tibial. If you don't have upper right, always consider this is postductal, and the pH will be higher, pH will be lower, and PCO2 will be higher. And the most important thing is your patient ventilated or not when you comment on your blood gas. Now, when you look at the slip, there are various machines. There is portable machines like iStat. There is big machines that can give you zillions of reading, and there is point of care machines that give you limited readings. So it's very important to look at your slips, and slips varies according to the machine. However, in general, you will see first part, you will see the temperature. Very important to look at the temperature of the machine and look at your patient. Is patient febrile or a patient is hypothermic? And then consider. If it's not, you need to readjust, and there is way of readjustment. Or you change your machine temperature to make it much easier. Change the temperature of the machine. So you will see your pH, you'll see your PCO2, you'll see your PO2, and you can see this patient is very hyperoxic. You'll see all the bacteria, and you can see ACT, the actual. Okay, and you can see the base excess, and when base excess, you can see it's base excess but has minus, so it's mean deficit. So these are the measured and calculated. You will see also what we call it co-oximeter. If you remember, when we put the SAT monitor, it's called oximeter. An oximeter measures the percentage of oxyhemoglobin. All the other hemoglobin, whether it's carboxyhemoglobin, whether it's a methemoglobin, whether it's a silver hemoglobin, whether it's M hemoglobin, will not be measured. It all will be considered anoxyhemoglobin. So if you want to measure other type of hemoglobin, you have to use what we call it co-oximeter. And co-oximeter can fractionate or measure all different type of hemoglobin. And when you see coaxihemoglobin, mean it will give you different type of hemoglobin like methemoglobin or carboxyhemoglobin or F oxygen or F hemoglobin. All the abnormal hemoglobin, it gives you as a number, like the total hemoglobin, and it gives you as a percentage. So you can see that the methemoglobin is 0.3%. Until 2, if you are not using inhaled nitric oxide, is okay. But if more than that, you are either have congenital methemoglobinemia, or you have you're giving some medication that increasing the methemoglobin. Then you will have something about the oxygen. So you will see total hemoglobin. You will see the what we call it oxygen, sorry, not hemoglobin, and you can see the corrected total oxygen. And you can see here also it gives you. Can you please mute your mic? Please mute your mic, Ahmed Mustafa. You can see that it gives you the B oxygen. I don't want to go details of what is B oxygen, but it's always lower than the actual hemoglobin by about 2%. And you can see that it gives you also the percentage of oxygen to how much you're giving oxygen to FiO2. And it gives you the total, it gives you also the total oxygen. And you can see also it gives you the corrected. See, this patient is hyperthermic, so they corrected the reading. They corrected the reading to degree of 39 degrees Celsius. So if you have normal temperature, you ignore this number. Okay, there's some machines automatically give you hyperthermic reading and hypothermic reading. It's set there. You can remove it, but it's always there. But when you look at these numbers, if it's the temperature of your patient is close to 37 degrees Celsius, you need to ignore this. Also, the machine will give you lots of electrolyte, different electrolyte. And this is a very good way to monitor electrolyte to minimize blood loss, but has very other advantage. If you do serum electrolyte and you look at your blood gas machine electrolyte and they are the same or they are comparable, then you have a very good accurately reading machine. So these are two benefits: minimize blood loss from repeating central venous sample electrolytes, and also comparing your blood gas machine electrolyte with the serum electrolyte. If they are comparable, then you have a good reading machine. Now, also you will see that the some of the slips will show you the entered values, like whether this is an arterial sample, the operator name, what's the location, how much you are on FiO2. You can see that we are on 30% here. What's your temperature? And again, you can see that this is a different way, a different machine give you a different, but the basics are the same. Now, how you interpret blood gas? Consider your clinical setting. Again, is it arterial, ABG, or capillary CBG, or a venous? And always compare, as we said, your serum electrolyte with your blood gas electrolyte. If they are comparable, then you have an accurately reading machine. And when you read, this is not P abnormal, this is abnormal. So this is a spelling mistake. Always first identify all the abnormal. You can mark all the abnormal and then decide, is it respiratory? Is it metabolic? And then calculate your anion gap if you have enough electrolytes listed or measured in your blood gas. When you talk, you need to consider your clinical scenario. Also, you need to make sure the time between the sample and the process and how you transport it and whether there is heparin or not. For example, in room temperature, you have to process the sample within 15 minutes. However, if you put an ice around it, you can process it up to 1 hour. And while you are doing the blood gas, are you evaluating a ventilation? You change the setting and you want to see the response? Or you did some therapeutic or diagnostic intervention, like you gave, for example, normal saline bolus, or you started inhaled nitric oxide, or you gave indomethacin to treat PDA, or you have a shock and you're using inotropes. Why you're doing the blood gas? Are you giving a medications that will change the blood status like milrinone or inotropes? So you need to make sure why you're doing the blood gas before you're interpreting the blood. So one of this is monitoring the ventilation. Okay. So my apology, I have two disconnection today. Never happened before. I don't know what's happening today. However, bag. So when you process the blood gas, look at your scenario, look at your time and how you transport, and then look why you are doing the purpose. What is the purpose of your sample? And consider other parameters. How much your FiO2, how much your hemoglobin, how much your total fluid. Do you have a good urine output? What is your lactate? No sound? No, the sound is working. My sound is working. Do you guys don't hear me?
We hear you, sir. Thank you.
Okay. Thank you. I'm sorry, I don't know what happened with the system today, but I'm disconnected twice. I don't know why. So again, when you consider your hemoglobin, good. So consider how much your FiO2 on, how much FiO2 on, and how much your hemoglobin. Remember, because hemoglobin is carrying oxygen, and the remaining of the hemoglobin will carry the carboxy, will carry the CO2, and therefore having higher than normal level hemoglobin will affect your readings. So it's very important to know your total fluid intake. It will affect your perfusion. What's your urine output? Is it more than 1 ml per kg per hour? That means you have a good perfusion, especially if you're doing CBG. What's your lactate? And lactates give you an idea about perfusion and also give you if there is metabolic problem. What's your age? And if you're premature, what's your digestation? All this you need to know it, in addition to the time of the sampling and how you transport it before you comment on the blood gas. And remember that pH and CO2 again is measured, while bicarb is calculated. If you need to know the measured bicarb, you have to send electrolyte. And remember that the bicarb calculated from this equation. If you're not sure, about your bicarb calculation and you think it's incorrect, send serum. And if you send the serum, the measured or the calculated bicarb should be within plus minus 2 to 3 millimole per liter of the measure. The serum measured should be within 2 to 3 millimole per liter of the calculated. And remember, 0.1 drop in pH, that means there is 10 millimole of H gaining. It's very important to remember that. Now, how you proceed? So you will start with the problem. Is it acidosis? Less than 7.35. And again, this is an arbitrary number. And this number change with gestation, with age, with different scenarios. But we have to use number to make the definition. So is it less than 7.35? Then it's acidosis. Is it more than 7.34? Then it's alkalosis. And remember, if it's bicarb, it's metabolic. If it's a CO2, it's a respiratory. So is your CO2 is high or your bicarb is low? Is it respiratory or metabolic? And then look at the alkalosis. Is your CO2 is low, then it's respiratory, or your bicarbon. And you can see when it's uncompensated, they never meet. They always on the reverse. When they meet, it's a compensation. When they are heading on the same size, on the same direction. So, and then now you know the problem, respiratory or metabolic alkalosis or acidosis. Is it, as we said, CO2, acidosis, respiratory, low bicarb, metabolic acidosis, CO2 is low, alkalosis, respiratory, CO2 is high, alkalosis, metabolic. Now, if they don't meet, it's not compensated. If they meet, it's compensated. Very important to remember that. You can see if they meet, they are start to compensate. So remember also, CO2 means respiratory. CO2 changes, respiratory. Bicarb changes, metabolic. If they are heading in the same direction, they are compensated. Now, what other things you need to do before you interpret? Is it this is chronic, or it's an acute respiratory changes? So if you look to the primary problem like respiratory acidosis, and because it's respiratory acidosis, it's a CO2 changes. What will happen to compensate? You increase bicarb, you add alkali to tackle the acidosis, to correct it. And when you add bicarb, it's in two situations. In acute, the body can add 1 milliequivalent per liter of bicarb for each 10 millimeter mercury of CO2 to correct. And if that's incorrect, there is no such relation. Let's say you have plus 2 milliequivalent of bicarb and only 10 change, then there is another 2 is metabolic. So this is very important to know when you compensate. While when you are chronic, it's better. It's getting better. It's getting experience. The bicarb has more experience now. So it can give 4 millimole for each 10. The questions will be, when you compensate, mean you return your pH to normal. Compensation means, the question, what is compensation means? Compensation, you get respiratory acidosis, which means your CO2 is high, which means your pH is low, less than 0.735. What bicarb will do, will add alkali to bring back the pH to normal. However, your CO2 is still high, and now your bicarb is high. So they are on the same direction. That means you are compensating. What compensation means? Your pH within normal range. Or remember, number is acceptable. Okay? What is the limit of changes that bicarb can do in an acute situation? It can do up to 38 milliequivalent per liter. After that, if you need to compensation, the bicarb cannot. And the baby will get more acidosis and acidosis. You need help. While in a chronic situation, it has more ability to compensate, 45 millimole. Now, if you have respiratory alkalosis, which means you are hyperventilated, which means you are washing CO2, your CO2 goes down and your pH goes up. So what bicarb will do, it will lose bicarb. Either you lose it by the kidney or you combine it with the water and try to send it to breathing. Can you please mute your mic? And again, so respiratory alkalosis, washing CO2, dropping CO2, high pH, the body starts to lose bicarb to bring the pH from high back to down. And we also have two situations. Acute, you have to lose about 2 milliequivalent of bicarb to bring your PCO2 by 10 millimeter to compensate for dropping 10 millimeter of your again, my apology for this interruption. You guys are keep interrupting me. So in acute situation, if your bicarb is high, if your pH is high, due to dropping CO2, so the bicarb will lose or spoiled or urinate by 2 to compensate for the changes in the pH that was caused by 10 millimeter mercury of CO2. So if CO2 drop by 10, it will increase pH. The bicarb need to drop 2 to bring the pH back. And in acute situation, the bicarb, I have a questions. No sound, are you sure? Anybody hear me? Do you guys hear me?
Yes, we hear you.
Yeah, so Infinix X, whoever your name is, you didn't change your name, you have a problem with mic and it's not the time for technical help. So back again, respiratory alkalosis, dropping CO2 by 10, you need to drop your bicarb by 2 to bring your pH back to the normal. And in acute situation, you can lose up to 18 milliequivalent per liter. In a chronic situation, you need to work more to bring the pH back because the body starts to used to it. So you need to lose 5 milliequivalent of bicarb to compensate pH due to loss of 10 millimeter mercury of hydrogen. And the limit, unfortunately, the limit during chronic situation get worse in alkalosis down to 15 milliequivalent per liter. So now you have to remember when you compensate whether it's a chronic or acute situation to judge your pH and your bicarb and your PCO2. Now also chronic versus acute metabolic. So we have metabolic changes. The primary defect will be the bicarb, and because it's acidosis, and because it's acidosis, mean you are dropping CO2. What will body do? Drop CO2. So C compensation, they are on the same direction. If it's not compensated, they will be on the other direction. Okay, so how you expect? You expect that for each of 1.2 bicarb, you need about 8 millimeter mercury of CO2 dropping to compensate, plus minus 2. Okay, or it can be the last 2 digits of the pH times 100. So let's say the pH is 7.27. So 0.27 times 100, you'll have 27. So the body can compensate by CO2 the last 2 digits of the piece of the pH. Can compensate the amount of CO2 that can compensate for losing or dropping bicarb. So let's say your pH is 7.45, then the body can compensate about 45 millimeter mercury off. Or the other way to calculate it is 15 plus the bicarb level. The limit of compensation is 15 millimeter mercury in both situations, acute and chronic. Remember, metabolic has no good connection with the chronicity. Now, if you have metabolic alkalosis, and this is wrong, and my apology for that. This is increasing bicarb, and the compensation is CO2. It's the other way around. Okay, this is typing mistake. So the metabolic alkalosis, then it's a bicarb. It's alkalosis, then your bicarb is high. Well, the body will compensate, it will bring up the CO2. How does that? You hypoventilate. You drop your ventilation. You have periodicity. You have apneas, or you have hypoventilation. And how the pH, the PaCO2, the changes of CO2 is 0.6 millimeter mercury for each 1 milliequivalent of bicarb. On the other way around, it's 15 plus the bicarb. And the limit is much higher here, the changes in CO2 during alkalosis. Because the body can wash a limit, because you can get tachycardia to wash CO2. So your limit is 15, while you can stop breathing at all. If I loaded with you and make you alkalotic, you can stop breathing. And therefore, you can see in alkalosis or in hypoventilation, the limit of CO2 changes is much higher. While in hyperventilation or in low CO2 changes, its limit is much, much less. Now, it's very important to remember, respiratory compensation is fast, which is occur about within 12 to 24 hours, while metabolic is slow. And therefore, it's mostly has nothing to do with the chronicity. So because acute is within short time, chronic with longer time. It takes always 5 to 7 days to correct itself. And therefore, it's not good, if you look at here, it's not good, the metabolic changes, it's not good with the chronicity. Somebody asked me, what is compensation? It's the body physiology response to bring primary pH changes to normal. And they are of 3 types. Full compensation, meaning the pH went back to normal. Now, how we know it's partial compensation? You'll see both CO2 and bicarb in the same direction, up or down, but the pH is not back to normal, so it's partially compensated. If they are in 2 directions, the PCO2 and pH, they are not compensated. If they are overshoot, and overshoot mean the primary defect is when you look at the PCO2 and bicarb, it's either metabolic or respiratory acidosis. But when you look at the pH, it looks like alkalosis. And that means you are overshooting the correction. And when you're overshooting, you have a mixed disorder. Again, for this very important point, if you have an acidosis, the bicarb and the CO2 are in 2 directions, no compensation. You have a normal pH, but the bicarb and the CO2 are in the same direction, you are fully compensated. You have PCO2 and bicarb in the same direction, but your pH still abnormal. You're partially compensated. You have PCO2 and bicarb up, and the primary defect was CO2 is up, so you have respiratory acidosis, but your pH is up too, which means alkalosis. That means you are overshooting the correction, and that means you are a mixed disorder, which is respiratory acidosis and maybe metabolic alkalosis, something like that. So remember, when you're overshooted correction on the other direction, it's a mixed disorder. Okay, I have a question. Is everybody hearing me? Do you hear me, guys?
Yes, we hear you.
Good. Hanna Walid, you have problem with your sound, not me. Everybody seem hearing me. So again, partial or complete compensation, you need to know full, partial, or no compensation. And the third changes, or the fourth changes, is mixed disorder or overshoot correction. Now, the other things is anion gap. And it's very important to remember one thing very vital in anion gap, because is the difference between cation and anion. And you can see some of the equations of the anion gap, including potassium, and others does not include the potassium. Both are correct. But when you do not include the potassium, you need to drop your value. So if you're including the potassium in the equation, in the cations part of the equations, you need to increase the number, the normal number, by 4. So instead of saying 10 plus minus 2, you said 14 plus minus 2. So it's very important to remember that. And an anion gap is the difference between cation and anion. So when you calculate this and you find it higher or lower, that means there is something else being adding to the circulation. This thing can be base, can be alkali, can donate or can receive by hydrogen ion. If it's normal, then it means there is nothing being add to the circulation. What does that mean? So if you are, for example, you have metabolic acidosis because you're losing the bicarb by the kidney, you will have normal anion gap. But if you have acidosis due to poisoning with aspirin, for example, or due to taking an extra medications, like for example, one day I have a patient and it's a premature babies and it's persistent acidosis despite we did everything right. Good perfusion, normal lactate, very well, normal CO2, but very high anion gap. There is no metabolic, congenital metabolic that we thought of, normal urine organic acid, normal serum organic acid, or the metabolic secrete are normal. We couldn't figure it out. And then later we discovered that mom was on benzene. So she was taking benzene and inhaling the benzene, the gasoline, and the baby was poisoning with benzene and causing high anion gap metabolic acidosis. So remember, when it is high, when you have high anion gap, that means you are adding something to the circulation. And that means you have to look to that something. When it's normal, there is nothing being added. It's the difference between the cation and anion. And therefore, anion gap, when it's high, the normal, as we said, it's 10 plus minus 2, but always remember to add or not the potassium. And measure. It can be anionic protein, it can be phosphate, it can be sulfate, it can be organic acid, it can be amino acid, it can be ketones, whatever. It can be uremia, it can be ammonia, it can be many things that can cause you acidosis. So again, anion gap can increase by increase of unmeasured ion and decrease by unmeasured cation. So if you have increased unmeasured ion or decrease of unmeasured cation, you get high anion gap. And ion gap may decrease if you start losing your electrolyte. Or you start to add cation, because remember the calculation, you have cation or anion. If this goes up minus this, you get high. If this goes down, you get low. If this goes high, you get low. If this goes low, it's just two sides of the equation. So anion gap may increase by unmeasured cation, like calcium, magnesium, potassium, or addition of abnormal cation, like lithium, or decrease in albumin. So each 1 gram decrease of albumin decrease the anion gap by 0.25 because it's cationic protein. It's unmeasured cation. Now there is a list and there is a mnemonic abbreviation that we use for looking of abnormal or increased anion gap. They call it CAT mobiles, and the list is here. I'm not gonna go through it. You can memorize it, but it's always there and it's been used. Now, what is mixed disorder? the most important in diagnosing mixed disorder is not the blood gas, is the clinical history. And when we say mixed disorder, mostly you will find the pH is normal, or what we call it full compensation. But you have abnormal PCO2 and abnormal bicarb. And remember, if it's compensation, they move in same direction. If they move in two directions, they are uncompensated. If the PCO2 and bicarb moving in opposite direction, it's uncompensated. But if they are overshooting the original problem, it's a mixed disorder. So again, mixed disorder, either both move in two different directions, or they're moving in the same direction, but the bicarb is moving in the other, I mean, the pH is moving in the other direction, overcompensated to the other direction. Because if you have high CO2, you have metabolic acidosis, your pH is down, your bicarb starts to go up. And then your pH goes back to where it was. But if your pH continues to go up, despite your CO2 is low, then you have a combined problem, or you are overshooting. If you are overshooting, it's a mixed disorder. And there is very important Flynn-Lee normogram that you guys, if you are like, you don't have experience, you are still novice with the blood gas, you can use it. It's a very good tool actually. And I'm going to show it to you the next slide. And remember, if the degree, remember when we talked about compensations, when we talked about chronic and acute, and we talk about the measurement, if they are not related, if the changes in bicarb is not related to the change, to the number in PCO2, then you have mixed disorder. So acid-base, use Flynn-Lee normogram, degree of compensation is not matching, and you can find what we call it delta gap. So again, clinical history, it will help you to mix disorder. Normal pH, abnormal PCO2, but they are moving in the same direction. Or overshooting. Acid-base, MAP, or Flynn-Lee normogram. Degree of compensation, it does not match the changes in bicarb and CO2. And then you find the delta gap. Now the Flynn-Lee acid-base normogram, very important. So if you draw a line between, let's say your pH is 7.3 and your arterial CO2, whether it's in Pascal or millimeter, let's say your BO2 is 80 and your pH 7.3, so you are here. Okay, so when the point reach, it will tell you whether it's a metabolic acidosis or it's a metabolic alkalosis or it's a chronic respiratory acidosis. This will help you to diagnose. When it's not matching any of these, it's a mixed disorder. So when you go in a color area, it's a primary problem. When it does not go to any of these areas, it's a mixed problem. So Flynn-Lee acid-base normogram will help you to find the mixed problem. The other way to help to find the mixed problem is the delta equation. So if the delta equation is anion gap divided by the changes in anion gap divided by the changes in the bicarb. And what does that mean? Normal bicarb minus the actual, and normal the actual anion gap minus the 12, the normal, and also normal bicarb minus the actual, you get the delta ratio. And if it's less than 4, it is hyperchloremic non-ion gap metabolic acidosis. If it's between 0.4 and 0.8, it's what we call it HAGMA, or high anion gap metabolic acidosis, or NAGMA, normal anion gap metabolic acidosis. If it's 1, 2, 2, it's uncomplicated hagma. If it's more than 2, it's metabolic acidosis, and maybe there is pre-existing increase in bicarb. And therefore, delta ratio will help you to differentiate between high anion gap metabolic acidosis and normal anion gap metabolic acidosis. Now, this is a summary. It's a very good summary. So we have respiratory acidosis, it's uncompensated, then your pH is low, your PCO2 is high, and bicarb is not changing. Example, severe asthma, pneumonia, and hypoventilation. Start to compensate, your bicarb will go up. But still, your pH is abnormal. It's partially compensated. You're fully compensated, still your CO2 is high, but bicarb is now moving in the same direction, and pH is normal. And this can happen in severe asthma, pneumonia, and hypoventilation. These will tell you it's a respiratory problem. In respiratory alkalosis, you have high pH. And it happens when you have hyperventilation, whether by ventilator or by panic attack, or you have a drug, taking a drug that causes you breathing fast, like fever, like aspirin, all cause hyperventilation. So when you're uncompensated, your pH is high. Your CO2 is being washed, your bicarb is not changing. When you start to compensate, it's partial, still your pH is high. CO2 is too low, and the bicarb, and start to compensate, you can see CO2 and bicarb moving in the same direction. When it's fully compensated, it becomes normal. Overshoot means it moves on the other direction, despite all in the same direction. It moves to the other direction. That's called overshooting. And when you are overshoot correction, that means you have mixed problem. Metabolic acidosis, uncompensated, you have low pH, but the problem is bicarb. The CO2 not affected. Example, diabetic ketoacidosis, lactic acidosis, alcohol, salicylate, whatever the problem is, or even low perfusion due to hypotension or uremia, whatever the metabolic problem, and then you start to compensate, to partial, so your pH is still low. Your CO2 is still low because it's a primary problem, but the bicarb is low now. So every V is low, then it's partially compensated. When it's back to normal and both heading in the same direction, it's fully compensated. And again, the metabolic alkalosis. Normal gas for newborns, venous, arterial, and blood gas. And I hate the name normal. I don't like it because I always like the scenarios, and I would like what I call it acceptable or permissible instead of normal. Okay, it's there. I don't like to memorize it, but you can see when in neonate you get the window better. The window is wider for PO2. When you are arterial, it's higher than venous, and you can see that capillary level, it's higher. PO2 capillary level, it's higher than venous. It's less than arterial. Now, I'm not gonna go to the differential diagnosis. I think you guys can read it. I think it's better if I answer the questions. So we have metabolic acidosis, pH less than 7.3. That means your CO2 normal, maybe low if start compensated, and there are different causes. And in metabolic acidosis, a normal anion gap or abnormal anion gap. And we talked about it. And there is a common causes. And I listed that for causes of lactic acidosis. So you have a metabolic acidosis, but you have lactate extra. And it can be primary lactic acidosis, or it can be secondary lactic acidosis. So you have a metabolic acidosis, low pH, but also your lactate going up. And it depends where you're measuring the lactate, with or without heparin. But usually the lactate should be less than 2. But again, it's arterial or venous or gas. So when you have a lactic acidosis, it can be primary due to metabolic problem, primary lactic acidosis, or it can be secondary to asphyxia or hypoxia, or RDS or sepsis, or whatever the reason. And it can be also due to various other reasons. I'm not going to go to the list. And you have normal anion gap. And again, normal anion gap, you are not adding anything to the system to cause higher anion gap, and you're not taking anything from the system to cause low anion gap. and you can read it. And you can see normal, we are losing bicarb, mainly losing bicarb, or you're losing from GI, or you are dilution. And always when you have normal gas, look to the factitious causes of acidosis. Are you adding a medicine to the patient, or the patient taking something to make it? It's very important to make sure that there is no air bubble, because air bubbles in the capillary that you do, for example, the CBG to insert to the machine, the tube, the small tiny tube, can have air bubble and can cause you acidosis. Always look what you are giving to the patient, and what's the food he's taking, and what's the drug. And low anion gap is very rare. I don't think you need to think about it. It's either lab error or your albumin is low, but it has nothing, no clinical significance when it's low. Alkalosis, we're gaining more bicarb. So it depends. Either you're giving acid or you're losing acid. You're vomiting. You're vomiting something. So because you're alkalotic. And it's again, it's either a chloride resistance or a chloride responsive. It depends on its type when you start to replace it. Because our talk is not about management of alkalosis. That's why I want to skip it. And again, it's here said more than 7.45, but it's not a must. It depends on the situation. Respiratory alkalosis, you are hyperventilated. Either you are inducing it by a ventilator, or patient is hyperventilated by medication or by a fever, for example, or he's panic. Acidosis, you are not ventilated very well. Your CO2 is accumulated and your pH is going up, and there are zillions of causes of respiratory problem that and even cardiac that can cause. But always remember your mechanical issues that can cause. For example, if you give surfactant to the patient, you'll get high CO2. So you have to do the gas after 2 hours of giving surfactant. Don't do it immediately. Or your tube is not in a good position. It's either you are high above the clavicles, or you're going down to the carina, or you're going selectively intubated one side. So mechanical issues can cause accumulation of CO2. Or sometimes you're just not suctioning very well. So if you think of that, you need to adjust your tube, do an X-ray, and suction well. And I think I'm done, and I would like to ask questions, but I would like